these are the faculty disclosures before, and of course, I will not spend time highlighting the complexity of the allogeneic stem cell transplant procedure. There are many complex parameters that we have to take into account, and when it comes to acute and chronic GvHD, actually we know that disease status, patient characteristics, the choice of the conditioning regimen, the choice of the graft source, the type of donor, the GvHD prophylaxis regimen, all of this will play a significant role. And this is why it's quite difficult actually to run trials in this space. What we clearly know is that over time, and despite the recent improvement, the incidence of acute GvHD remained stable over decades. We don't have the most recent statistic with the introduction of post-Cy or maybe post-Cy plus ATG, but we also know, and again, we don't have the most recent statistics, you may tell me it has decreased, but still, because of the older age, because of the wider use of PBSCs, because of the use of systematic DLI, because of the use of high-risk transplant of high-risk diseases, the incidence of chronic GvHD and the severity is increasing. And of course, you're all familiar with the first-line treatment of acute GvHD, the famous standard of care of 2 milligram per kilo per day. In some cases, you may wish to use 1 milligram per kilo, but we should not forget that this is helpful only in 50% of the patient. So it's still a true unmet medical need in my opinion. And of course, when it comes to steroid refractory, steroid dependent or steroid intolerant patient, the situation can be more complicated. And this is where ECP can play a role. This is a very, I would say, fascinating technology, and I must confess we don't understand 100% the mechanism of action, but definitely it's about immune modulation and trying to induce tolerance through this system. And I think you are well familiar, for instance, with the machine and the way it works and the use of the UVAR XTS technology. And usually it is quite straightforward as a technique. And at the end of the day, because this technology would allow to restore a sort of a balance between immune stimulation and immune suppression. This is why it's not an immunosuppressive agent. Actually, it's more an immune modulation towards induction of tolerance, and this is exactly what you're looking for in this situation. The history, you know it very well, 1987, then 1994, the first GvHD case, and there is an amazing number of publications since. I'll share quickly this case study with you. 60-year-old female, no comorbidities, high-risk AML, first CR induction consolidation, high-risk disease, allotransplant, HLA identical sibling, classical regimen flu-bu ATG, cyclosporin alone, PBSCs, good recovery of neutrophils and platelets, and then of course we have seen the GI and liver manifestation. So what is your treatment approach for such patient, please? Is it wait and watch? Is it local treatment? Is it corticosteroid 1 milligram per kg, ECP alone, or you would combine ECP and steroids? Please vote. Okay. We'll try to convince you that there may be room to improve this. Okay, next. Second case, 50-year-old black male with MDS, received mismatched 9 out of 10 reduced intensity conditioning, peripheral blood stem cell transplant, cyclosporin MMF ATG for GvHD prophylaxis. And this patient, despite the absence of acute GvHD, 9 out of 10 mismatch, developed sclerotic chronic GvHD, eye involvement, oral involvement by the 3rd month. We started prednisone, 1 milligram per kg, continued cyclosporin. He achieved PR, but definitely the burden of chronic GvHD was high. What would be your approach in this case? Wait and watch, add ruxolitinib, introduce ibrutinib, introduce ECP, or maybe another option like belumosudil. Please vote. Okay. Interesting. Well, definitely, ruxolitinib is not available at this stage in the UK. So these are the European colleagues from outside the UK probably responding to ruxo. ECP, more than 1/3 are introducing ECP, excellent. Ibrutinib, it's not widely used in Europe and not approved. Belumosudil, interesting. It is approved actually in the UK. So in summary, we believe, and if you are doing transplant, acute and chronic GvHD remain serious complications after allotransplant, despite the most recent improvement. Obviously, the holy grail for us in transplant is to separate GvHD from GVL. I don't believe it's going to happen very soon, but we do have some great progress, and things are improving, and this is where we believe that in addition to all the other available drugs, ECP can continue to play a role.